Welcome to Mercy Medical Center's live webinar. I am Lynn Harmon, Program Coordinator, and today's topic is chronic pain. Joining us is Dr. Ken Cearlock, Mercy Palliative Care Medical Director, and Joni Henderson, Nurse Practitioner. After the discussion, they will take questions from our audience. If you are a regular attendee of Mercy's webinars, you may have noticed the format of our webinars has changed. The method to submit your questions has also changed slightly. Hover your mouse over the green bar at the top center of your screen and then click on the question and answer icon at the far right of the strip. Then from the drop-down box, select host and type in your question. Your answers will be confidential. Well, I'm very happy to welcome you both to our webinar today. I'm going to turn the mic over to Dr. Cearlock now so we can go ahead and get started.
Thank you, Lynn. And I'd like to welcome those of you who are logged on to our webinar this afternoon. It's a privilege for Joni and I to both be here to share some information and have a little open discussion, perhaps answer some questions. And what we really like to accomplish is your understanding a little bit about this difficult situation that patients encounter all too often that's known as chronic pain. You'll see listed the program objectives in front of you, and in prefacing that, I'd just like to say that you're tuning in thinking that you're going to listen to some experts that deal with chronic pain, and we have quite a lot of experience, but I just want to share with you once on WMT I heard the horticulture master gardener saying that an expert in gardening is someone who's killed more plants than anyone else. So I will tell you in preface that Joni and I have experience, but maybe our expertise comes in knowing what sometimes doesn't work or what to avoid, and also to be very humble and share with you the fact that there's not any physician, there's not any team of caregivers that really have a total monopoly or a handle or an understanding of the immense individuality and the difficulty that pain presents in our culture. We're going to talk about definition of pain and then make a contrast between the fact that pain is not all bad. We're put together, our bodies are responsive and have pain messages to protect us, to keep us away from injury and from trouble. But that chronic pain is a different type of a response that the body has developed over time that really becomes counterproductive to our function, to our ability to enjoy life day to day, and it definitely gets in the way of production, of our work, of our enjoyment of family, and of just our day-to-day experiences. It's thought that chronic pain costs in the range of $500 to $600 billion of medications and treatments and cost to our healthcare system, loss of productive time at work, and so forth. We're going to talk briefly of some typical treatments for chronic pain, and then Joni will take over quite a lot with the last item in which we present many optional methods to manage chronic pain and why we have a palliative care team that helps the physicians and the caregivers in our community to be there as a resource to try to help people who have suffering from chronic pain. With that as a backdrop, I'd like to just have for you a definition that's presented by the International Association for the Study of Pain, in which pain is described as you see on the screen, an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So we have pain in our bodies, and our nervous system is designed so as to protect us. So for instance, if you've twisted your ankle or jumped down and fallen and a bone is broken, you probably experience pain immediately so that one knows not to keep trying to walk and to keep functioning if there's been an injury that's occurred. You reach out and touch the stove burner, it's really important for you to have a pain sensor that protects you from this potential of tissue damage. And so one of the questions out there for you all is that as you may experience pain or know of loved ones or acquaintances who have pain, to what degree is the pain something that actually prepares and warns us and that protects us, and then at what time does it become counterproductive? And that's the key, I think, that I want to present to you, at the fact that chronic pain is something different. It has the characteristics and has all of the emotional and all of the mental and the memory type of things that we recall from our development that protect us, but it now has become exaggerated and amplified to where it gets in the way and in which we perceive things that are not really having the potential to injure us. Now, as one of the things that has been noted in the literature is that chronic pain is not just a condition, it's not just a description of symptoms, but it rather is a diagnosis in and of itself. It occurs when our nervous system, which normally has various chemical signals and nerve passages and parts of our brain that interpret signals and then cause us to react or have a reflex to protect us, gets thrown out of its normal balance. So chronic pain is something, a sensation that we experience that goes on longer than we would expect. In general terms, the body tends to heal up in the range of 6 weeks to 3 months. If you have a broken bone, if you have a bad bruise, if you sometimes have a bad pneumonia that persists. In general, that's a time frame where we'd expect a normal healing process to occur. Pain will give us a signal for a while. If you have had a burn or a fracture, if you've had your appendix out, whatever it might be, we would expect a normal time frame where, in general, our bodies will heal. Chronic pain is a different circumstance. What tends to occur is that the messages, the signals that protect us just stay on. The switch just gets flipped on, and now we have ongoing signals of pain that are outside the realm and outside the normal time frame of when our bodies would normally be expected to heal. As a characteristic then, it tends not to resolve on its own because our nervous systems have developed a perception of pain that is abnormal. And then it becomes frustrating because as folks come to me as a physician and say, I have this terrible pain in my belly, there's got to be something there, and all the x-rays and the examination findings and tests that are done show nothing, it becomes frustrating. That's a pretty characteristic circumstance that happens when we develop chronic pain. The clinical or the objective observable signs are oftentimes not there. Now, that fourth bullet point is extremely important because one might ask, why then, if all of us go through circumstances, we have injuries, we have illnesses, we have infections, we get broken bones and so forth, why doesn't everyone develop chronic pain, and why do some people develop chronic pain and it just seems to never go away? There is a tremendous correlation between underlying psychologic circumstances, and that there's many reasons why a person might have anxiety or underlying depression. It could be family support or lack of a support system. It could have to do with a trauma that's been very difficult, creates just a constant memory that's hard to get over. But at any rate, there is estimated to be 2 to 2.5 times the prevalence of background anxiety and depression in folks that end up suffering chronic pain. It's not that the anxiety and the depression happen because of the chronic pain, but a lot of times folks have pre-existing problems, that particular medical condition that exists or predates when the chronic pain circumstance or an injury occurs that then leads to a chronic pain circumstance. We'll explain this a little bit further, but the final bullet point there is that it is often neuropathic in character. Now, we sometimes will define, for instance, if a person has a shingles infection and gets that burning, searing pain, or an individual suffers diabetes where the nerves become injured, that may be described as a sharp or burning, and it's described as neuropathic. But I'd like for you to think of this definition of neuropathic, meaning that the nervous system is pathologic. It's not behaving in the way that normally it would, and so there is now pathology. There's an abnormality of the way in which our bodies perceive the sensory input that occurs, and it is out of it's out of realm or out of measurement or out of perspective and proportion to the actual stimulus that's occurring. So we'll define that a little bit further of what neuropathic pain means. Just for brief, various types of pain that are described. Acute pain occurs, of course, what I talked about with something, an accident, a surgery, and so forth. You see that word neuropathic there, means that it's a nerve type of category of pain. So a lot of times if a individual has say an auto accident, an injury, or we're in a fracture of the back or a injury to the spinal nerves coming out from the disc spaces become injured, that might be a nerve type of pain. But once again, I'd like for you to think of neuropathic being sort of characteristic of the chronic pain circumstances. Visceral means inside of us, inside our lungs and our abdomen, and bone, of course, is a common one that people tend to have happen. These are described and are characteristic and can be treated in specific ways and with a number of different interventions. But all of those types of normal responses of the nervous system can persist longer than we would expect and lead to chronic pain. So we talked about 3 months in general, either 3 months or 6 months is a definition of pain that persists longer than we'd expect. But some folks define chronic pain as just a pain that goes on longer than the typical healing circumstance would be expected for the individual to experience in those sensations. Now, briefly, we take off on a lot of different approaches to dealing with pain, both acute pain, but in our discussion this afternoon, we want to talk a bit about the treatment of chronic pain. Most importantly, I want you to hear from me as a physician that we do not want to emphasize or have listed first, or even in your own mind prioritize, the medications, the prescriptions, the pharmaceuticals, and so forth. They are a tool that we have. However, there are many, many other interventions and ways in which the individual has capability to get that pain better under control, to process it, to interpret it, and also to adapt to it that don't require a lot of medications. In everything that we use as far as treatment of chronic pain, there's a benefit that might be expected, but there's also marked concern about side effects of any particular individual medication. And then as we add in medications from different categories of molecular structure and the way that our bodies use those pharmacologically, there end up being side effects and interactions that are undesired and may actually aggravate and worsen the condition an individual has. Up at the top of the list, and one that we want to focus on because it has become a bit of a two-edged sword. It's one that when I go in or when you go in to have a a gallbladder surgery or you're having your knee replacement, you want to make sure that the doctors caring for you are at least offering you that first category of medication known as an opioid. Those are derivatives such as morphine and hydromorphone and a whole array of opioid derivatives that have been processed and formulated so that they're either short-acting, long-acting, can be given IV, by oral administration, or even put a patch on the skin so that it can absorb that way. They are the mainstay of acute pain treatment, along with the second category, the non-steroidal anti-inflammatory drugs. So those are the Advil, the ibuprofen, Aleve, those things that are over the counter, and there are about 5 or 6 categories or different families of that same category of medication that have their own characteristics and may be specifically used for an individual. So those are some of the important ones that we use. Adjuncts is probably, and it's a term that the folks who are researching pain literature and pain investigation really would like to kind of stay away from, because it's tough to define what that is. What I'll describe to you as an adjunct is anything else that we prescribe that may be either a medication that you can get over the counter or that you need a prescription for that isn't an opioid and isn't a non-steroidal. So we might look at the anti-anxiety medications that treat depression, medicines that treat seizure disorders that also have a tendency to stabilize our peripheral nerves and cut down on the abnormal messages that our bodies perceive. There are corticosteroids, prednisone, and so forth. So you don't, if you're a baseball player, you don't want to use those, but we use them a lot in folks that have chronic pain or that might consider. There are also topical ways where, for instance, the numbing medicine, xylocaine or lidocaine that you go receive at the dentist for a tooth extraction or a filling can be given by way of a patch that goes through the skin and so forth. So anyway, not to go through all of those categories, but we look at those as possibilities. Now I want to just real briefly talk about the difficulty of the use of narcotics. And the first and foremost, I want you to understand that there really aren't any studies that show that the narcotic use over long term really benefits us. Doesn't get us back to work any faster, doesn't keep us back at work, it doesn't make us feel less pain scores, and it ends up having a lot of side effects. The narcotic category of medications present a very significant challenge as far as side effects, and then also what's known that happens in the body, a process of tolerance. So while in the acute situation, narcotic medications are very effective and necessary, if you will, they aren't real good using them over a long duration of time. And part of that is just based upon studies, and low back or back pain is a very common area of the body that develops chronic pain as a result of injury or so forth. And the studies show that there just isn't good efficacy with long-term use of narcotics. There's a lot of tendency for dependency, and also even use of them as far as diversion that physicians have to be concerned about, where there's a street value of these particular medications because of the euphoria that a person might get. So I'm going to transition a bit, and that's a brief introduction of pain, what differentiates chronic pain as being a pathologic or a neuropathic response where the body's perception is different from normal, and some people describe it as a sensitization or a hypersensitization to any even basically non-threatening stimulus, and our brains perceive pain in a different way. There's a lot of tools we have to treat this, But right here is the important thing. In our involvement as a palliative care team, the goal is for the individual suffering chronic pain to learn how to control their own responses, perception, and their own management plan. So that's, with that backdrop, I'm going to turn over to Joni just to go through some ways in which a team approach is extremely important for people suffering chronic pain.
Thanks, Dr. Cearlock. So there are a few things just to keep looking at that we can look at besides medications for helping the individual with chronic pain. And as you guys know, it's not just the individual that's suffering it, it's also their family. So we tried to help the individual get their pain under better control so that it helps with all aspects of their life. So on this slide, you can see the middle circle is the individual. So the things that we use to help that individual with their pain control. At the top is palliative care, and I'm going to go through each one of these bullets a little bit. We also use a lot of psychiatric care, stress reduction, exercise, and physical therapy. So if you look at the top left side of the slide, the thing we look at with psychiatric care is we use pain psychology. We have a great pain psychologist here at Mercy Medical Center who helps people with how to refocus their pain. When they start to develop pain, what can they use outside of medication management to help with achieving better pain control? They also have at Mercy a chronic pain support group, which as a lot of people in chronic pain know, is that you feel like you're the lone person on an island. In reality, there's a lot of people with chronic pain. The benefit of the support group is you find other people and you find what works for them and what hasn't worked for them. Again, everything's very, very individual, so those things that work for other people might not work, but it's always good to have brainstorming sessions and find out how to help yourself. But again, it's that whole idea of there's other people out there with you suffering the same pain, and as I said earlier, what works and what didn't work. Psychiatric provider. This a little goes back to when we talked about anxiety and depression. There's a high incidence of anxiety and depression with chronic pain. And there are psychiatrists out there who are extremely good at pain management with using some of the medication that is used for depression or anxiety to help with multiple aspects. But that psychiatric provider is very instrumental. We talked about anxiety and depression medications. There's, you always hear those advertisements like for Cymbalta or, we can't even get the other ones off the top of my head, but medications that help with pain along with helping with the anxiety and depression. And sometimes if you can help keep the anxiety under better control, it will help with keeping the pain under better control. And then cognitive therapy. Some of that is biofeedback, or if you start to develop some pain, how can you do some refocusing or some meditation or anything to do to help get the focus off your pain and more on how to focus on your wellness. So under stress reduction on that bottom left, massage, extremely beneficial. We have a lot of people that use massage that helps with relaxation, but also helps with improving pain management. We know that within even our palliative care team that if somebody's getting massage, it helps with decreasing their pain and ideally helping them refocus on living their life again. Meditation, also real important. Again, that goes back to refocusing and trying to get the focus off the pain. Leisure time activities. How many times you've heard people say, I can't go golfing anymore. I can't go fishing anymore. I can't do this or this or this. Ideally, people who can get back to their leisure time activities feeling like they're living life again. So there's ways to adjust those leisure time activities to help. So people getting back into leisure time is important. Acupuncture, we find lots of good people that have good relief with acupuncture. And then wellness coaching. So to do with that is people who are exercising are going to have better pain relief. People who get their weight under control are going to have better pain relief. Anything just doing, watching what you eat is going to help with that. Off to the bottom right, exercise. swimming is a great exercise for pain relief because it doesn't put a lot of pressure on, and it stretches a lot of muscles. Even if there's therapeutic temperature pools, that's very helpful. Stretching, I think stretching is probably one of those underrated things that people don't do enough. But if you're going to go out for a walk or if you're going to go do some exercise, stretching is very important. Joining a health club. Again, that kind of goes along with that support group. You find other people who are exercising and being healthy and trying to get healthier. So health clubs are a good benefit. And then strength training, just along with cardiovascular strength training, doing some weights, doing items that are going to help increase muscle. Physical therapy. So physical therapists will use ultrasound. Ultrasound helps give a deep pain relief to affected muscles. Home traction, like for people who have maybe cervical injuries, they can set up home traction equipment to help stretch out the neck to prevent further pain. Heat and ice, whatever works the best. And then just physical therapy, again, how to teach the person how to use their body correctly to prevent further injuries. And then we're going to talk about palliative care. So palliative care, we do quite a few things too. We have a whole team of people with palliative care. So if we find a particular circumstance that we find puzzling or just want to talk about, our team gets together routinely, and it includes a physician. We have pastoral care, we have nurses, we have a pharmacist, we have a social worker. The whole idea is to have a whole holistic approach to, have you tried this yet? Have you tried this yet? So one of the things we do a lot is medication trials. And like Dr. Cearlock said earlier, it is trying to find what's best for that one individual. So we might try something for a short amount of time. If it works, great. And if it doesn't work, how do we tweak it a little bit to help with better pain relief? Team counseling and support. Again, it goes to and trying to help that person understand they're not the only person on the island, and that how to refocus. Our pharmacist will do a pharmacy review to say, they're very competent at knowing what different forms of medications you've tried and what might be beneficial. Spiritual care, along with our pastoral care, there are people that have pain because they're feeling some conflict within their spiritual care. So what our pastoral care person will do is evaluate that and to see how they can help with improving spiritual care. And then nutrition counseling. That kind of goes back to that wellness coaching and trying to find the right combination of diet and exercise that will help improving pain control. That's a brief synopsis on the program, and I'm going to give this back to Lynn for questions.
All right. Thank you both for sharing information about chronic pain. I want to remind our listeners that your questions can be submitted by hovering your mouse over the green bar at the top of your screen. Okay, our first question is talking about acupuncture on the pain management program example slide. Can you address this? And then she goes on to say, yes, I see it now. But Dr. Cearlock, is there anything else that you would like to say about acupuncture and its successes?
Yes, and this acupuncture is one of the additional measures that we have, and I can't stress that enough, in that a lot of the things that Joni and I prescribe as caregivers with prescribing, licensure, and so forth, like I mentioned, have a benefit to be expected, but they also have a lot of potential side effects that we have to consider. As far as I know, acupuncture is a relatively painless to go through and very, very minimal in side effect. And I would I guess I just give a plug a little bit. I've listened to Dr. on his program on the WMT, where callers will talk about various conditions. First and foremost, I respect his capacity and his experience and his knowledge. but also the fact that he will be very forthright to tell someone if their particular condition is unlikely to be helped by acupuncture. So specifically, acupuncture is very, very important as another what we call a modality. It's a means of treatment that can be used. We have all sorts of machines and gadgetry that we use. A TENS unit might be considered somewhat akin to acupuncture. And even massage and so forth has some characteristics of trying to find areas of the body that are tensed up, and that by whether it be an acupuncture needle, a massage, a therapy stretching, or a TENS unit, or even a just heat or ice that one would do at home, anything that will change the maladaptive sensation that's being transmitted to the brain through the spinal cord, if you can do something to change that, that's very much to be considered. So acupuncture is extremely important, and any of these other modalities too. Now, the one precaution I always have, and very important, is that you want to research things, because anytime people suffer with a chronic condition or looking for answers, you can kind of get set up to be scammed a bit, and there are some not always ethical and quite expensive interventions. You just want to research and maybe ask people and ask your physician and so forth of which ones to consider and which ones to kind of be a little bit cautious about.
Okay, very good. Next question, does Medicare pay for palliative care? I'm going to hand that one over to Joni.
That's a good question. So what Medicare will pay for palliative care is they'll pay for the physician or the nurse practitioner or a licensed social worker. So where the rest of our team, the nursing staff, the pharmacist and all that, that's not paid for by Medicare. But like I said, the providers, they do get paid for.
Okay, next question, what about the use of the copper bracelets that I hear about in Asian medicine? Dr. Cearlock, can you take this one?
Okay, again, a very good and often something that comes up as a possible consideration. I've had a number of folks over the years. The copper bracelets seem to have been developed, or at least in our Western culture, have been embraced as far as use for like arthritic conditions and so forth. So I've had a number of patients over the years that have used them and stated that they work a lot better than the ibuprofen that I've been prescribing for them and so forth. So that's a consideration. There are all sorts of, there's magnet therapy, there has been the pyramid you'll talk about, and a lot of these various treatments are looking at natural occurring substances that have a particular molecular structure. Every molecule has sort of like a little solar system around it, whereby we have energy fields and so forth. The way that a person has an MRI test now, that's basically the theory of how protons revolve around, create the molecular structure. So we look at different tissues and how we can image that. So there is something to the fact that metals and so forth might actually change the energy fields that make up the nervous system. Once again, the problem with a lot of these alternative therapies is that in our Western culture, and in the United States particularly, a lot of things that are utilized and that are paid for by a particular insurance company have to have some degree of what we refer to as scientific testing. Now, that oftentimes involves some type of a double-blind or a double-blind crossover study where you apply a treatment to a group of people, the other group doesn't get it, get that treatment, and sometimes you actually, in the middle of the study, you cross them over, and they need to not know if they're getting a treatment or not. So with these things, that it's hard not to know that you're getting acupuncture or some of these other things. So the problem comes in, how do you study and compare, and for a large group of people, apply something that might be very beneficial to an individual but can't be reproduced by way of a study. So that tends to become, and I'll just jump ahead because I see a question that has to do with the affordability of alternative treatments and the fact that they may not be covered by insurance and so forth because they haven't been FDA approved, or they haven't been shown to be effective in a particular medical literature or whatever, or physical therapy or chiropractic literature, any other treatment forms. So that does become an issue. It does not mean that they're not good. It doesn't mean that they shouldn't be a consideration, but cost can indeed be an impediment. Look at some of the things that could be similar to, just to the non-covered treatments, to see, for instance, physical therapy, or even like some insurances cover chiropractic. So there are some knowledge about alternative treatments that are part of those disciplines.
Okay, very good answers to those tough questions there. Next question, what about nerve blocks? Are they an option, and what are the risks and benefits? And I think Joni's going to take this question.
That is a great question. We have a group of people who will develop severe back pain or sciatica pain. And if the medications aren't helping, a lot of times we will refer to interventional pain management. And they will do epidural injections or nerve injections into the actual nerves, and it can work really quite well. We have people who have pain. They might get an injection in a week or 2 weeks. They have significantly less pain. The benefits, I mean, it works. I mean, it can work very well. It's not going to, probably isn't going to work 100% of the time all the time, but it's going to work well. The risks to that, very little. It's just if it doesn't work, they really don't recommend doing it again for 2 to 3 months. So we have really very good luck with interventional pain management. The next question talks about that the person feels like they're taking so many drugs and supplements. Do the pharmacist review and carefully set up a trial to get off some of the drugs? Yeah. So for palliative care, what we do is we always have a referral from the family physician to look at things. And then between the pharmacist and the provider, we can work with the person to help start decreasing this. And like Dr. Cearlock said, narcotics for long-term isn't usually the answer. So we would be very willing to help people. And the key is that individual has to want to get off the medications. And we're talking about pain management because, blood pressure medicines, that's a whole, insulin, that's a whole different ballgame. But pain management is extremely important, and we do like to get down to the minimal number of medicines you want.
Okay, thank you, Joni. Next question, does arthritis make scoliosis worse? And then there was a continuing part of that question that it appears got cut off from our listener. But Dr. Cearlock going to address this topic.
And for those of you logged on, the follow-up of that question, will an injection help for pain? Now, just some definitions. Arthritis is a broad category of possible diagnoses. It in general means that there's some type of an inflammatory condition that involves the joints. So where the bones come together, those are our joints, and arthritis is oftentimes an ongoing, it could be an acute problem, but oftentimes it does fit into the category of a chronic condition, although it may not be a chronic pain syndrome. It has a specific cause that can be measured sometimes by way of some blood tests or some joint fluid evaluation and so forth. Scoliosis is a curvature of the spine. It means that bones, the blocks of bone, and all the different parts of each level of the vertebra are not lined up the way they should be. So that creates a setup for back pain and so forth. So indeed, there are some types of arthritic conditions that can make that scoliosis worse. I would also say, and alluding to, referring once again to what Joni had said, exercise is a huge mainstay of treatment for chronic pain. So in this particular question about arthritis making scoliosis worse, arthritis hurts. Scoliosis is an abnormal alignment of the spine and the musculature, to the extent that stretching and exercise can be applied that helps the musculature and so forth. The way our bodies are created is we have the bones as sort of a foundation or an anchor inside of our skeletal structure, and then bones and ligaments and so forth attached to, and they actually support a lot of the bony structure. So yes, it can be made worse. Now, there was a question about injection for pain, and depending on if it's localized to a particular area, certainly a injection might be a trigger point into an area of inflamed or spasmed muscle, or it might actually be into the epidural space. That's inside the spinal column itself, overlying the nerve root, where some analgesic medicine or a corticosteroid would be applied. So that is a possibility then. And let's see, should I follow up with the next question, which you can all see there? Sorry, I can see it. So you guys are all out of luck. I can see it. So now the question is how can we help family in dealing with our chronic pain? And the questioner is saying, I try to complain only a few times a day, but it wears on them. What's available to them to understand and get support? Tremendous question, and this really hits at the heart of what I think our webinar this noon is centered upon, is that chronic pain is a whole person challenge. It's a whole person diagnosis. And in fact, it is a whole family, or even sometimes coworkers or friends and so forth. We'll see an individual with chronic pain and suffering. They'll want to help them. They'll sometimes say things that aren't very helpful. They'll sometimes suggest, and they will lack understanding of what an individual is going through. So what in our palliative care team, a lot of times that can actually be something that enhances or aggravates or contributes to ongoing chronic pain if the individual doesn't feel support from family, or not uncommonly, somebody who doesn't suffer this condition will have a notion that, well, you need to bite the bullet a little more. You need to toughen up. You need to kind of get with the program. You've kind of taken it easy too long, whatever. And those can be very hurtful, and not that they're intended to be hurtful, but sometimes in motivating, loved ones do not understand what an individual is going through. So having some medical information about what we think in theory happens when an individual has chronic pain, and then what it takes as far as support and how to allay the anxiety and the feeling down the dumps, the feeling of frustration, and in fact sometimes interpreting something that may be well intended from a family member that might actually make you feel even more down and more painful, either physically or emotionally. So I would suggest, the pain support groups we talked about, counseling sessions. Counselors are glad if family members are willing to come along just to understand a little bit better. And our palliative care team, too, oftentimes will have a family meeting when we're doing an evaluation or trying to help out, or even coming out and doing a home visit for someone to have family there that are key to the support of an individual, because that understanding and support, and also knowing how to hear you when you're hurting is incredibly important. So I appreciate that question, because it speaks to the immense umbrella of our lives that chronic pain can sometimes occupy.
Okay, thank you. We're going to switch gears just a minute here. What about the issue of marijuana use for pain management? We're hearing it in the news a lot. Could you address that? Dr. Cearlock, I believe, is going to take that question.
Okay, and that's one that's kind of contemporary right now, and if we were in Colorado, we'd have a lot more information, I suppose, to have an experience with this. Right now in Iowa, that's not an option, and there are some sort of derivatives and some preparations that sometimes can be used for end-of-life care to help stimulate appetite, and that can be utilized as one of those adjunct pain medication. But in general terms, for chronic pain and for acute pain, that's not something that's available to us in our state and in a number of other states, although it seems to be increasing. Not sure that the evidence, it's more individual. It's kind of what we refer to in medicine as anecdotal. I mean, somebody says, well, it worked great for me, but we just don't have studies that show that it's efficacious or a good array of actual medical information about the mechanism and whether or not its beneficial effect is not inordinately offset by potentially dangerous side effects, dependency being a tremendous one of those. So.
In case you have questions that you don't get a chance to ask, I know we had a couple pop up on the screen and disappear before we had a chance to really read them. I just want to point out that if you have additional questions, you can address them at the phone number on your screen, 319-398-6860. Another question just came in. How do we go about working with your team? Do you need a referral from the doctor? And it looks like Joni's going to take this question.
Yes, to work with our team, we do need a referral from your doctor. So just from the family physician, and they can contact at the number on the screen right now, 398-6860, and then we can set up an appointment. And then there was one about when do the support groups meet. That would be done out of Dr. Luke Hansen, and he's an outpatient psychiatry. So to call Mercy and ask for Dr. Luke Hansen's area, they would be able to get you that information.
Our next webinar topic is coping with stress for families of children with autism. The speaker will be child psychologist Carolyn Maniza of Mercy Family Counseling. It will be broadcast on Tuesday, February 18th at noon to 1, and she will take questions live after the discussion. Now, a question came in asking you could get copies of the slides. A tape of today's program will be available at the website listed on your screen right now, mercycare.org/live. And this is usually posted within, sometimes within a couple hours, but certainly within a couple days. And then you can check back to this website for information about future webinars and listen to past webinars also. If you are interested in future webinars, you may also sign up for Mercy's electronic newsletter, and this is at mercycare.org/e-news. Another question, we've had great questions here today. Why is an SCS unit considered experimental? Dr. Cearlock.
Okay, and thank you for that question. Just for everyone out there, a SCS, meaning a spinal cord stimulator unit. And we mentioned a little bit of a little gadgetry that's available called a TENS unit, a transcutaneous nerve stimulator that is kind of on the outside and the little patches that give an electrical stimulus. Much like acupuncture and many of the modalities we use, if we can do something to alter the maladaptive nerve messages that the body is sending from our whatever part of our body is painful up into the spinal cord, going into the brain, and then coming back down as a pain message, that can be very, very helpful. The spinal cord stimulator is a little bit more, lot more, I should say, invasive as far as a treatment. But much like an epidural or one of those injections into a nerve root and so forth, these types of things are done. What happens with the spinal cord stimulator is that a electrode is placed in around an area of pain or above, so as to thwart some of that messages that are coming up to the brain in the pain pathway, and it in theory is to be very effective. One of the things that we have observed, and why a lot of times there may be insurance companies not paying for it as yet, is just the experience and the benefit and the consistency of good effect that folks get. As it works, an individual gets a trial attempt, and that's just sort of a brief trial, as it is just maybe an hour or two or a half hour to see does it help. The problem is then when that electrode surgically is placed in over the spinal column, it has a tendency to shift around. You have a wire that's going down into the body, and there are risks of infection and so forth. There have been some folks who've gotten benefit from it, but it, like many new treatments, sometimes it's jumped onto and it's utilized before all the kinks are out of it. And so we're looking at that, and if you're going to consider it, you want to be very, very careful, make sure that all other safer treatment options have been considered before you go that route.
I think we have time for one more question. If you had problems getting through with your questions, the number on your screen, if you have any follow-up. But one last question here, Dr. Cearlock, is related to people with fibromyalgia. Is there any new research or medications coming soon? Would you like to just quickly, in the time we have left, address this big topic?
Yes, once again, a very important area of topic, and certainly one of the conditions that fits into that definition of chronic pain, because this is one that oftentimes when an individual is afflicted by it, it's not something that is there for a bit and it goes away. It has to be managed. It becomes sort of baggage that you carry with you for quite some while. Historically, when fibromyalgia was first described, there was a little bit of slow embracing of it from allopathic physicians, or we so-called scientific types that want to see evidence and obvious information that defines a syndrome and so on. Because of the self-reporting and the subjective nature of symptoms that an individual gets, it was a kind of a slow go as far as the physician community saying, yeah, this is indeed a syndrome, this is indeed a diagnosis. There are some actual objective findings that define fibromyalgia, different from just say a regional pain syndrome that involves an area of pain that just goes on without any objective findings. Usually with fibromyalgia, there is actually some inflammatory component of it, where there will be trigger points and they can actually have redness over the skin in those areas and so on. Ongoing research, indeed, because if you could find the cure-all, that'd be just wonderful. Unfortunately, much like any other chronic pain condition, any research, any particular developed product is going to work for some and not be effective for other folks. And so you have to look at all the different options that are out there. I don't know of anything specific other than I know that these serotonin norepinephrine uptake inhibitors like the Cymbalta, Savella, that are the main ones that are approved for, the newest ones that are approved for fibromyalgia, probably new things are going to be in that same category of medication. Can't stress enough to not rely totally upon medications, but exercise, and it may have to be paced exercise. You may have to go do half of what you're accustomed to or a third of it, but don't give up on it. Even though you're hurt, even though the joints and muscles ache, don't quit doing the things that you enjoy. You just may have to modify how frequently and how long of duration that you can tolerate.
We had another question come in here. We just have wrapping up our time, but just I think one time for this last question, do you think any herbal vitamin supplements help pain management at all? And it looks like Joni may take this question.
Yeah, that's the same kind of thing as when Dr. Cearlock talked a little bit about the copper bracelets and magnets. There are things that can help, and again, it's all very individualized, especially the vitamin supplements. If somebody's deficient in a particular vitamin, the supplements might help. Same with herbs. So the big thing to do is to make sure that it's not interacting with any other medications you're taking along the way. So if it's helping, it's well worth it. Just make sure there's no other interactions.
This is Dr. Cearlock again, just to add to what Joni had said. There was an interesting study of one of the common herbals that's used by folks suffering arthritis is glucosamine or a combination glucosamine chondroitin. There are no medical studies that show, and the way that scientific studies are done, that show that that is effective over and above placebo. However, if you interview and you ask and you quiz people who take it, 50% of people will say, indeed, this is helping me. I feel much better than when I am not on it or have not been taking it. You do have to, in order to say that it's not going to work, supposedly have to take it for several weeks, even up to 2 or 3 months. So it's a, again, much of our subjectivity is what it means, and so if it is effective and safe for an individual doing it, we encourage that to be considered. So, and I think there was something about referring to accepting patients, and also going to a number of different doctors and not getting anywhere. And so our palliative care team is here, and we do function in the outpatient setting, and both in an office setting, and sometimes Joni does quite a lot of visits out in home and nursing homes and so forth. So if you're interested in, it doesn't have to be chronic pain necessarily, but our topic, and that's something that we have a good crew of folks in our community and here at Mercy and within the various departments and our palliative care team that we can tap into resources. So if we can be of help, we'd like to be here for you.
Okay, I believe we have covered all the questions that have been submitted to us today. Many good questions and obviously great answers from both Dr. Cearlock and Joni. Again, I thank you all for joining us, and we'll look forward to having you join us for future webinars. Thank you.